Hello, my name is Fred Noller, and today we'll be talking about chest x-rays. I'm a PA and I work in critical care, and this is something that I use multiple times on a daily basis at work. I literally don't go a single day at work without looking at a handful of chest x-rays. So learning the fundamentals on how to reading a chest x-ray will really help your practice. And there's a system that I use that I think will be beneficial for you as it has been for me to navigate a chest x-ray to get the most information quickly from the information that you ordered. I use the technique called the ABCDEs of the x-ray. So I'd like to share that with you. So we'll move along here. So with some objectives of this presentation, we'll just briefly talk about the history of the chest x-rays, talk about some indications, contraindications, some limitations about the chest x-rays, some different types of x-rays. Talking about chest x-rays, we do anterior, posterior, and then posterior anterior, and lateral images of chest x-rays. We'll look at each x-ray and we'll determine if it was technically a good x-ray as in terms of this technique, or it's a good bad technique, and how we can make that determination to be able to get accurate information from our interpretation of the x-ray. We'll use our anatomical knowledge of the chest to find the anatomical landmarks on the x-rays, and so that we can determine what's normal and what might be abnormal on those x-rays, and support our diagnoses. And we're going to integrate our knowledge of our physiology and pathophysiology onto these x-rays and to help us interpret what's going on with the patient, whether there is a progressive disease process going on, or is our interventions helping our patient improve, and we can kind of just see that on x-ray. For instance, is pneumonia getting better after 4 or 5 days on antibiotics, that type of thing. And we'll look at some imagings to determine the correct placement of medical devices. Some history on the X-ray. Several scientists in the late 1800s were studying different types of rays, radio waves and things of that nature, and they developed this cathode ray. And they noticed that when they were applying radiation from this cathode ray, they noticed a shadow of an image that would pass through different barriers such as paper or cardboard or wood even, that there would be the shadow of an image that would be projected past these barriers. And they experimented with different objects, including like a deck of cards and books and things like this. And this is actually an image of Wilhelm Conrad's wife, hand. This is one of the earliest images captured of a human anatomy on X-ray, and and little did they know that this will be so ubiquitous and used in medical clinics and hospitals around the world, and just billions and billions of images from this initial research. It's quite amazing. Uh, Marie Curie is a prominent scientist, and she's also studied different radio waves and X-rays, and even used X-rays to apply to different therapies, such as skin lesions and rashes. She uses different radiation waves onto these skin lesions to help cure them. She won a Nobel Prize in medicine for various studies such as chemistry and radiation therapies and things like this. And she used that money to fund X-ray field ambulances during World War I. And she established more than 200 X-ray departments in hospitals across Europe during World War I. So she was a major catalyst to provide this amazing diagnostic tool that we just really take for granted. It's a technology that is still so heavily utilized today. Some indications for chest X-rays are many. You'll be having, you'll see a patient and they'll be having different symptoms or complaints, and if somebody's will require you to order some diagnostics, and a chest X-ray is one that could be very useful. Patients come in with shortness of breath or chest pain, coughing, sputum production. They might have fallen on their chest and have chest pain, so you want to see if they have any fractured ribs or and things like this. You'll be examining someone physically and notice coarse breath sounds or even a deviated trachea. These types of things would indicate a chest X-ray. Also, we will do X-rays after we do a procedure. We'll place central lines or chest tubes. The cardiologist will place a pacemaker. The PAs will even, such as myself, I'll put in a dialysis catheter, and after I put in a dialysis catheter, I will do a chest X-ray. So just to make sure that the placement is correct and didn't cause any injuries such as a collapsed lung or pneumothorax. Also, we do chest X-rays for screening purposes. Someone's coming in for their annual physical. Some people, for employment purposes, will need chest X-ray every year if they can't get the skin test, the PPD test for tuberculosis. Maybe they had a vaccine from their home country for the tuberculosis, so they can't get the skin test, the PPD test. So they'll need to get the chest X-ray to rule out they have any signs of tuberculosis or whatnot. Screening for cancer or other foreign bodies such as metal fragments if they need an MRI for some reason, and they never had an MRI before. The MRI tech will ask if there's any foreign bodies, and if there's unknown or the patient can't speak for themselves, such as they're on the ventilator or whatnot, we'll need to do a chest X-ray of their chest and even their abdomen and whatnot to rule out any foreign bodies before an MRI. And also we do chest X-rays for follow-up. We started antibiotics, for instance, and we want to see if the pneumonia improved, or if is there a progression of a disease process going on, and we want to kind of have serial chest X-rays to monitor that. And also before and after a procedure such as thoracentesis or draining fluid from the chest, we want to see if the fluid reaccumulates, or if we got all the fluid, or we may cause a pneumothorax from the thoracentesis. So we want to follow up on those types of things. So these are not a complete list of chest X-ray, but these are many, and there's certainly many more. So this is a very commonly used diagnostic. Some contraindications of a chest X-ray. There's really no absolute contraindication for a chest X-ray. Of course, you want to evaluate risk versus benefits in certain populations, such as pregnancy or maybe pregnant. Certainly, you want to worry about pediatric populations and utilize as little bit of a radiation exposure as possible in the pediatric population. Also, we can use shielding to shield sensitive areas such as their reproductive organs or the thyroid, for instance. You can shield the areas that you don't want radiated with lead aprons and things like this. So those are really the only contraindications of chest X-rays. Risk, of course, for X-rays are radiation exposure. These can cause biological injuries, within the cells that can overwhelm their ability to, repair themselves. Examples of this is skin damage, cataracts, even sterility, radiation sickness, injury to the fetus, these types of things. Excessive radiation dosaging in the fetus could cause growth restriction, mental retardation, and microcephaly. We utilize a concept in radiology called the LARA. It's as low as reasonably achievable. That means the radiation that we're going to expose this patient to. Um, so the number of chest X-rays or the type of CAT scan, if we order a CAT scan, those machines try to use as low as possible radiation to get the images as possible. And so we want to limit their lifetime exposure to radiation. So there are some good things and bad things about chest X-rays. So some of the good things, the strength of chest X-rays is that it's widely available. You can go into an outpatient clinic and sometimes they'll have an X-ray machine there, urgent cares, things like this. Some rural clinics, some austere settings, such as third world countries, will have um, some X-ray machinery that they can take pictures. So it's widely available. It's economic. It's not that expensive. It's actually low dose radiation as compared to CAT scans, because CAT scans are taking many images all at once, where X-ray is just a single exposure for one image. So that's some of the strength of the chest X-ray. Some of the bad, of course, is just radiation exposure. Still radiation, whether you have one or many. Again, the special populations will be careful of the pregnancy and pediatric populations, like we discussed earlier. And if you you can often consider in these populations using other modalities such as ultrasounds or MRI to try to image that same spot if you wanted to avoid chest X-ray. And also we can use shielding such as lead aprons and whatnot. And the other weakness of a chest X-ray is actually a 2D picture of a 3D structure. So you got structures in front of each other, behind each other, and with an X-ray, it just takes a 2D picture. So in your mind, you have to kind of project what might be behind certain images, and you might not be able to visualize them as well. And if you have a concern or that there's something hidden behind there, then a CAT scan would be, or an ultrasound would be a better modality. So types of X-rays that we order, most of the time in the ICU setting, we'll use an AP, which is an anterior posterior view, where the plate will be placed behind the patient on their back, and you shoot the X-ray from the front, their anterior surface to the back. That's one of the most common um, uh, X-ray that we'll do. Sometimes we'll do a lateral view, which is this view here, where we shoot from the side. This is the same patient here. We see there's a little consolidation here in the left lower lobe, and we can kind of see it getting behind here in this cossopharyngeal angle in the posterior portion of the patient. And sometimes, here's your diaphragm. The infiltrate might be behind here, so it will be helpful to do a lateral in this situation. But it's difficult to do that in an ICU bed. This is usually done with the patient standing up in the radiology department. So laterals are not commonly used unless you have a specific reason to do it. We have lateral, right lateral decubitus view, where we'll lie the patient down and to see if this fluid will layer out. So this fluid is layering out here on this lateral view. So if you have a pleural effusion, say here, and you want to see if it's a thin liquid or it's thick, you can lay the patient down. If it layers out, then you know it's a thinner fluid, a thinner pleural effusion, and it might be amendable for thoracentesis or drain from there. If it remains in this position, it's more of a consolidation, or it can be an empyema, where it's more of a pus situation, where it's thicker, would layer out. In an outpatient setting, sometimes we'll do a PA image, which is a posterior to anterior view, where the patient's chest will be on the film and the radiation is shot from the back through the front. There are a little bit of advantage to this, where the lung fields are more visible. As you see on the traditional A&P that we'll do like an ICU, You have the scapula that might be in the field of view, where on the PA, the scapula is outside the rib cage area. And also on an AP image, the heart is a little bit more magnified, a little bigger, where the PA, the heart silhouette appears just a slightly little smaller. But there's real, so those are the differences between an AP and a PA imaging modality. But most commonly, it will be the AP that you'll see in the ICU setting. So what exactly are we looking at? So when the X-ray is taken, the radiation goes through what you're imaging, and the X-ray or radiation is absorbed by different densities. So air had no density, relatively speaking. So none of the X-ray is absorbed, and it's indicated by just this pure black. So the blackest here is just air, and as it moves through the different tissue, skin, fat, muscle, gradient starts to take up some of the X-ray radiation, and it doesn't make it to the film. Therefore, it starts the different gray shades of gray here. And as the density increases, the images appear more and more white. So bone will be whiter, and then metal will be the brightest of all. So you got these metal sutures in the sternum, so they are very bright, and then an aortic mechanical valve in this image here. So this is how the X-ray is formed when they take the image. And what exactly we're looking at continues. So we're going to superimpose our understanding of anatomy onto the X-ray image, and we're going to look for normal, and we're going to look for what's abnormal on the X-ray to kind of support or confirm our differential diagnoses. So we'll be going through different images to kind of determine what's going on with this patient. So the first thing we do when we see a chest X-ray is we kind of evaluate, was this a good radiographic technique, or was it not so good, and we might need to take the image again, or can I get the information I need? Just if the technique wasn't good, just understand that it may be necessary to not jump to any conclusions, and maybe redo the image, or just understand that you don't want to rule out something that's maybe there, or vice versa. So one of the things we do first when we look at an image is the penetration good? Is the film overexposed or underexposed? And we'll take a look at some images. We should be able to see the thoracic spine behind the heart, or through the heart silhouette. And we'll take at all the X-rays. We'll be looking at that. Also, is the good inspiration. Good radiology tech will say, take a deep breath and hold, and watch the patient take a deep breath and click the image. If the patient is sedated on a ventilator, they'll wait until a mechanical breath is given and see their chest rise. And when the chest rises to the fullest, they'll click the image. Also, is the patient rotated on the board on the X-ray film? So the image is a little off center, and we'll look at that as well, because it could change the way things look. Magnification, we talked about the heart, the AP versus PA, where the heart silhouette may appear larger or appear magnified. So just be aware that if you think the heart looks a little bit on the larger side, just kind of make sure it was a PA versus an AP film. So it may not be pathologic. And also, when you take an X-ray, if there's other prior X-rays, you want to take a look at those. Like if they had an X-ray yesterday or last year, you want to look at both of them and kind of compare. And angulation um, uh, is the angle which the X-ray was taken. Of course, if you have the film here and the patient here, you want to shoot the X-ray, perpendicular. But sometimes the patient's in bed, or the X-ray machine might become at an angle, and that can cause an angulation of the image on the back of the board, which could change the way things look. And I'll point those out as we come across those examples. For our purposes, we're just really going to concentrate on the penetration, inspiration, rotation of the X-ray. So when you have an X-ray pulled up, the first thing you want to do is make sure that you have the right patient, that you're not looking at somebody else. You verify the patient name, the medical record number, date of birth, and the date of study. When I was doing this lecture, I actually had a patient in the ICU where I pulled up their EMR, and they were literally there a year ago to the day. And there was an X-ray ordered, but it wasn't done yet. And when I pulled up their X-ray history, it was the same date but last year. And I clicked on the image, and I was looking at it, and the patient came up intubated, but on this picture the patient wasn't intubated. So I'm like, wait a minute. So I looked back, and sure enough, it was the year was last year. So I almost looked at that X-ray and just assumed it was today. So you definitely look at the dates of the study as well. When you look at the penetration, whether it's over or under, you want to see the spine through the heart, like we mentioned. The inspiration on the X-ray, you want to see the diaphragm around the 9th rib. Also, the rotation, we'll look at this, the spinous process. You'll see that on the X-ray. Is it equilateral between the clavicles? If it's deviated to one side or the other, it can indicate that the patient is rotated. Okay, so we're gonna take a look at this X-ray and kind of go through our technique here. So the penetration is that here's the heart silhouette, and this is the aortic knob there, and we can see the vertebrae in between, on through the heart. So this is a good penetration. Inspiration, hit the diaphragm here. We're going to count ribs. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9. Here's 10. So it's like 9.5. So that's a good inspiration X-ray. So if the diaphragm were here, this lung tissue might be all bunched up and appear more dense. So you got adequate aeration here, adequate inspiration. So this is what you want to look at the lung tissue in this phase. Magnification. This is a AP film. So we're going to know this AP film. So that might project the heart silhouette a little bit larger than normal, but this is still within normal size. And angulation. You're going to look at the clavicle heads here. And you want to kind of like 3 or 4 ribs down. So that's 1 here, 2, 3, 4. So this is a good angulation. When you have a higher angulation, sometimes the clavicle heads will be down here. So just be aware that if things look a little unusual, and it may be related to your angulation. So this is a good angulation. This is shot fine. And lastly, I did put here on position. If you have an image that, like I say, was done at bedside, and this was all cut off because they didn't position the film correctly behind the patient, then you're just going to ask them to reposition the film so you can get this back into field of view, because you want to be able to evaluate what's over there. And sometimes I see patients that have this part cut off on the X-ray, and you want that there too, because there might be a collapsed lung up here, in the apexes of the lungs. So if there's any portion of this that is not in your field of view that you want there, just have the X-ray technologist retake the image. So we're going to use our ABCD method, which I have here, and we also compare bilaterally. So first thing we look at this X-ray, is the technique good? And at first glance, it does look good. I can see the thoracic spine through the heart. I can see the spinous processes here, equilateral to the clavicle heads. It's not shifted over here or shifted over there. So the spinous processes are good. The clavicle is down about 3 or 4 ribs here, so that's good. So this was shot, perpendicular to the film. So that was so technique-wise, this is a good film. So I can move on with the rest of my evaluation. So I use the ABCD method. So the A would be airway. So I look at the trachea here, and have to come down here. Right here, I see the carina. I'm going to get this out of the way for a second, and oh, that's the wrong button there. And here I see the left main stem come up to the carina there, and then the right main stem. So there's the carina there. So the trachea is midline. Next is breathing. I'm going to take a look at the lung field. I'm going to take a look at all the lung field, and I'm going to see these little wispy lines here. I should follow them all out to the periphery of the lungs. This little white wispy thing all the way out to the periphery, and I'm going to look all through the entire lung field, up and down, and the same thing on the other side. I should see these little wispy lung markings all throughout. So I got good aeration here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is almost like a hyperinflated lung, a little more than 10, but it's not underinflated. And I got lung markings all the way to the periphery, so there's no pneumothorax. And I'm going to also look bilaterally if there's any consolidations or anything that's unilateral. So if I see white consolidation here but not over here, that might be an indication that there's a consolidation or pneumonia or even a mass. Cardiac silhouette. I'm going to take a look at a cardiac silhouette here. So this is your ventricles over here. You're going to see the left side of the heart the heart's going to be mostly on the left side of the chest. So I see that it's more on this side than on this side. I see the aortic knob here, and you want to be less than 2/3 the chest from side to side here. So this is a normal size cardiac silhouette. Next is diaphragm. So I'm going to take a look at the diaphragms here. This is the right diaphragm, and this is the left diaphragm. So the left diaphragm has air in the stomach bubble, so this is the stomach bubble. The right diaphragm is all whited out, so it's a solid, and that's where your liver is. So this is normal. And also you want to see your right diaphragm is always going to be like slightly higher than your left diaphragm. And you're going to see more of like a dome shape. So this is like a normal diaphragm. Also, you want to take a look at what these corners are called, costophrenic angles, or CPA. And you want to see nice crisp angles here. And E would be everything else. So I want to look at bones, and I want to look at all the ribs, and I want to look at both sides. I do everything bilaterally. The spine is straight. Sometimes you'll see deviations like scoliosis. The clavicles are equal. There's no clavicle fracture here. Also look in the soft tissue. I want them to look the same on both sides. Sometimes we'll see some air here. If they have a collapsed lung and air is leaking out into the subcutaneous tissue here, we'll see what's called subcutaneous emphysema. And we can compare it to both sides. Typically, when you have subcutaneous air, it's not bilateral. It will just be one side. So you always want to compare both sides. And also, I'm looking for any wires or tubes or any devices such as a pacemaker here, and I don't see any of that. So you want to look for hardware as well. So this is case one. We're gonna again go through our process. So first is our technique. It's maybe a little bit underpenetrated, so the thoracic spine is a little bit more difficult to see through the heart, but I kind of make it out, but not as good as the one we just saw prior, but doing okay. Here, the rotation wise, you see the spinous processes are kind of straight down the middle of the vertebral bodies and in between the clavicular heads. So rotation wise, it looks good. Angulation, we got 1, 2, 3, 4. So the clavicle heads are around 3 or 4. So that's good. So this is the image was shot perpendicular through the patient, which is good. So technique wise, this is pretty decent. Again, the technologist put on a marker here that says this is the patient left side, and this is also a PA standing. So it's a front or posterior to anterior. So this cardiac silhouette will be not enlarged. So now we are going to do our ABCD. So trachea, we can kind of see it, the silhouette here. This midline, kind of lose where the carina is. I don't really see it too well here, but the rest of the trachea is midline. Lung markings, I do see lung markings out to the periphery. You see the lung markings throughout here, 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 and all out through the periphery there. But I do see a white density here that I don't see here. So I'm looking bilateral and I don't see it over here. I see this section here and nothing there. I'm looking at the diaphragm, next, I'm sorry, as diaphragm, yes. Domed, right is a little bit higher than the left. I see costo-pharyngeal angles. And I see a little bit of an air bubble in the stomach. And another thing we want to look for is any free air underneath the diaphragm, where it would actually kind of highlight the diaphragm underneath. And that could be indicative of a perforated viscus or perforated bowel, and the air is leaking out and then tracking up and collecting underneath the diaphragm. And that would be a surgical emergency as well. So, and E is everything else. So bones, ribs, both sides. I don't see any fractures. I don't see any subcu air. I don't, from the bones that I can see, the humerus, the clavicle, the scapula, clavicles, humerus, scapula, everything looks intact. The spine looks straight. So bones look fine. I don't see any subcu air, and I don't see any hardware. So what I see here is this infiltrate here, this increased lucency here versus here. So my interpretation here would be a right middle lobe infiltrate, and this will be consistent with pneumonia. And when you read a report from the radiologist, they don't know this patient. You examine this patient, you took a history of this patient. They might have complained of fevers and rigors and productive sputum and things like this. And you listen to their chest, and they got coarse breath sounds over here and things of that nature. So you have a history, you have a physical exam. Your radiologist does not. So your radiologist will not read this and say pneumonia. They will say right middle lobe infiltrate, and this can be consistent with pneumonia. So they may even leave that part out, but they'll say right middle lobe infiltrate. But you, as a clinician that examined this patient and ordered this diagnostic, you can diagnose this patient with a right middle lobe pneumonia. This is just another example of a right middle lobe infiltrate. You'll see something like this. This is actually a necrotizing um, uh, organism. You can see, I'm going to move my little indicator out of the way. You're going to see like a little dark spot right where my circle is going to be right there. And you see a little bit of a dark spot here. Oh, right through that rib, you'll see like a little dark spot in there in that same little um, uh, infiltrate here. And when they do a CAT scan, it's actually tissue that's super infected, super inflamed, and this organism is actually causing necrosis of the tissue here. So the tissue is dying and just creating a little void, and it's a necrotizing type of organism. Um, so you can actually see that on the X-ray there. So that's just this another example of a pneumonia. This is another case. So technique-wise, it looks good. We can see the spine through the heart, which is spinous process. It's this little mark there. I'm going to try to highlight this, like this little triangle right there. See a little triangle right there, and it's equal distance here to here, here to here, and on the clavicle head, it's equal. So if you notice that this might be deviated over here, then your patient is rotated. So if your spinous process is pointing that way, say, then other structures in front of it will move this way, like the trachea will be moved over here a little bit. So so that's why we look at the spinous processes there. So technique looks good. Got 1, 2, 3, 4 clavicle heads around 3 or 4. So technique is good. So A, our trachea, it's coming down in the midline a little here a little bit. So that's good. I can see the left main stem here and the right main stem. So the crine is right here. B is our lung fields. So I'm looking at the lung field and I'm seeing like there's definitely a harsher look to the lung markings. They're a little bit, more bold, thicker, and they're bilaterally. And you kind of see this thickening part here. It's kind of curly B lines. You'll hear that with some pulmonary edema. So this is indicating to me that there is a diffuse tissue thickening of throughout, and I got a little curly B line there. And all the markings go out to the periphery. Doesn't look like there's any pneumothorax. Now we're going to go to C. That's cardiac silhouette, and I got this very large cardiac silhouette. It's mostly on the left side, but it's still very large. On the diaphragm, there's still dome. I can see a little costopharyngeal angle over here. I kind of lose it here. I see it maybe out here in the periphery, but I can't really make it out over here. So not really clear on the left. And I'm going to look at everything else. So bones look pretty intact throughout. I don't see any subcutaneous air, and really no fracture and no hardware. So my interpretation is cardiomegalia, so large heart with pulmonary edema all throughout. And this is consistent with heart failure. So you got a large heart failure, and you got very diffuse pulmonary edema with some curly B lines. Got a line, I'll change this little here. Got a little line there, and this. Got these little kind of streaky type, and they're usually in the bases. I think there's a little one here. So this is consistent with volume overload. So this patient would benefit from something like a diuretic. Our next case, we are going to do is our technique good? I kind of make out, uh, I can see the vertebral disc in between, so I can kind of make it out. And the spinous processes are some, I don't make all those out either. So this is a little bit maybe underpenetrated. So I'm going to take that into account with my evaluation here, that I may miss something or maybe overread something, because things might appear more prominent when they might not be, such as like a lung infiltrate. All right, so I'm going to, now that I got my technique, evaluation down, I'm going to move on to A. So I can see a little bit of a trachea here. I think I see maybe the carina about there. It's kind of hard to tell, but it's somewhat midline. I don't think it's deviated. I think if it was deviated left or right significantly, I think we would see that. So I'm assuming it's kind of a midline. Lung markings. I'm looking at the lung markings. I see lung markings all out to the side, to the periphery. But then I kind of don't see my costophryngal angle down here. I can see a costophryngal angle here, but I kind of get it here. And then I see this kind of meniscus sign here. So that's indicated to me that there's fluid in this left base. And C, cardiac silhouette. It's probably a little large. It might be normal, but there's fluid here, so it might be appearing that this heart board is really large. It only comes out a little bit on the right side. If you recall from the previous image with the cardiomegaly, it really came out. So if this only come out a little bit, maybe you might have a more normal cardiac silhouette, but it's hard to tell with this pleural effusion here. So that's our cardiac D. Now we're going to go, you see, we're going to go D. Here's our diaphragm. We can see a little costophryngal angle here. We don't see here. I don't really see a diaphragm here. I do see the colon here. So that might be helping us with the diaphragm, highlighting the diaphragm somewhat, but I can't really tell. Bones, looking bilaterally. The ribs look fine and intact. There's no subcu air. Humerus and the scapulas and the clavicle all look fine. There are some EKG wires that are going across. This is like a little button for the gown the patient may be wearing, and the radiologist put an indicator that this is the right side, mobile erect, and the DF is the radiologist's initials. So you can kind of sometimes identify who took the image. So my interpretation here will be a left pleural effusion. And if I want to know if this is thin, I could order a decubitus where I can lay the patient flat and see if if it will layer, and if it does layer, it will indicate that it's a thinner fluid, and I might be able to drain it. And here, it's a pretty odd catheter here. It's kind of like a little pigtail, kind of an odd spot. It might be trying to attempt to get into the space and drain that fluid, but usually it comes from this side and kind of curls. But I'm not quite sure why it's lying on a patient's abdomen. So this is a kind of unusual presentation. So there is some sort of hardware here. This case is pretty striking. So we'll go through our process. Is this a good technique? I think it is. We can see the vertebral spine through the heart silhouette. We got the spinous processes here. They're equal distance on the vertebral body. They look like they're equal distance to the clavicle head, so the patient's pretty well flat, not rotated on the image. So this is a good technique. So trachea, airway, is midline. We got the left and right here. Carina is about there, not deviated. B, and now we're going to go B for breathing. Lung fields I don't see any lung markings. It's very clean and clear. Over here, I got lung markings all throughout, but I don't have any here. There is a distinct line here, and my costophryngal angles were kind of cut off here. I don't really see them, but this one looks pretty crisp, and that looks crisp, but I can only assume. I don't really know because it's outside my field of view. Diaphragm is still kind of domed. This one's a little bit higher than the left as expected, but I just kind of cut off down here, so I don't have the full picture. But then now that's D. Now we're going to E. Look bones bilaterally. I don't really see any fractures in the ribs. I don't see any subcutaneous air. Clavicles look okay. But here it's really concerning. This is all air. It's almost as dark as the air on the side. And so what this is a right pneumothorax. So the air is inside this chest and is pushing the lungs, collapsing the lung up against the one side here. And this does not look like a tension at the moment, like a tension pneumothorax. If you would see a deviated trachea over here and this heart border pushed over, so now all the heart's on the left side, this could be what's called a tension pneumothorax. So this is probably getting very close to that tension pneumothorax. So this is a emergency. This needs to be decompressed right away and a chest tube placed. So you as a provider, you can put in a needle in the rib space here to decompress this space, and then it needs to be followed up with a chest tube on the side to re-expand this lung. But if this patient's starting to be hemodynamically unstable, it's an emergency and you need to take care of this right away. Depending on what setting you are, if you're in an outpatient clinic, you need to call 911. If you're in the ER, you're decompressing with a needle and putting a chest tube in. If you're working night shift as a hospitalist, you need to call surgery, or if this is like an emergency, you can decompress with a needle to re-expand. Of note here, this border here is the scapula. So you see that border there. And this is just a snap from their the gown that they're wearing. Okay, this case. So technique-wise, I can see the thoracic spine here, the ribs. I can see the spinous processes are kind of midline. The clavicle heads are kind of midline. So this is a good perpendicular shot. And the exposure is good, not over or under. So airway, kind of follow the trach, is kind of deviated now, so it's deviated to the right, and I can kind of see the left main stem and right main stem here. So something is pushing the trachea over to the right. So B for breathing or lung fields. I'm looking at the lung field. I see lung markings all the way out in the periphery. This is a rib there. You got some hilar markings here, which is just your blood vessels coming off to your lungs and some lymph nodes and things like that. So there are hilar structures that are kind of a little bit prominent there. But on this side, I see just a complete whiteout. I don't see any lung markings. There's really no air here, where you can see air here, but there's none here. There's complete whiteout, and there's so much whiteout here that's also pushing on the structures here. Cardiac silhouette is hard to define. I can maybe see a little bit here, but I can't identify any cardiac silhouette on that left side. Diaphragm D, domed on the right. I see costophryngal angled, and I can't differentiate where the diaphragm is on that left side. Bones, from what I can see, I don't see any fractures. I don't see any dislocations or anything like that. Arms are up, so you see the clavicles are an more acute angle. So their arms are up out of the way for this picture, and I don't see any subcutaneous air in the tissue. So my interpretation is here is a left hemothorax versus left very large pleural effusion. So we don't really know. So in this case, we'll need to know what the patient's history, what happened to this patient. Did this patient have a really bad fall or accident where he might be bleeding into his chest? Does this patient have a history of cancer, lung cancer, where he has what's called a malignant pleural effusion, where the tumor is just producing so much fluid that it just filled his chest and is pushing everything over? So this is where a good history and physical will need to take place to kind of differentiate what kind of fluid this is. If this patient had fallen, you might not want to stick a chest tube in there right away to drain all this, because it might be on blood thinners for some reason, and this might be kind of tamponading itself off, meaning it's kind of bled into his chest, but now it's kind of filling up and it's hard to bleed more. But this is also a lot of blood. Like for acute blood loss to fill up your chest, this patient's in big time trouble. So you need to kind of consider a little bit of what's going on. Plus, if this patient is hemodynamically unstable with this much fluid in his chest, meaning that is now pressing on the heart and not generating a good cardiac output, such as blood pressure and things like that, that you need to relieve some of this fluid to take that pressure off the heart. And plus, this might be uncomfortable for the patient breathing wise, might be very short of breath and things like that. So if you start draining some fluid off, start getting this lung inflated, so the patient might feel more comfortable, and then the heart will function better. So you have to take the clinical picture with what you're going to do next. If the patient's unconscious, low blood pressure, tachycardic, this is an emergency. If the patient is talking to you, conscious, and blood pressure is acceptable, you have a little bit more time. All right, technique-wise, I can see my trachea, I can see the spine through the heart, and clavicles are equal, and the spinous processes are in the middle of the clavicle heads and the vertebral bodies. So good technique. So A, B, C, D, E. So A, airway, I can see my trachea here is midline. B, I'm looking at my lung fields here bilaterally. I got good aeration. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yeah, 10. The ribs are starting to get a little hard to see there. But I see really harsh lung markings all throughout, all over the place. But when you look at the heart to see, I kind of see like a normal size heart silhouette. So at first I'm thinking, well, this could be a pulmonary edema, but I see a smaller heart. Now, you could have a heart failure for some reason acutely without having cardiomegaly or enlarged heart, but you also have to also take a history of this patient as well and kind of figure out why they're having this harsh kind of lung markings bilaterally. D, they're kind of domed. I see crisscross-pharyngeal angles, so I don't have any fluid building up here, so that's less likely heart failure. But I also see E on everything else. The bones were intact, but I see this line here coming in, and this is like a med port catheter where it's inserted under the skin, and this port is under the skin as well, and they can place a needle in there for like chemotherapy or something like that. So my interpretation here is that this patient has interstitial lung disease. So it has some sort of lung disease that's causing this thickening of the lung tissues throughout. It's not edema, it's just more like a scar tissue or thickening of tissue. And that could be related to chemotherapy. Some chemotherapies can cause interstitial lung disease in patients and cause like a restrictive lung problem. where the lungs become very stiff and it becomes hard for them to oxygenate and sometimes even ventilate, control their CO2s. So that's interstitial lung disease. Next case is so let's technique. Uh, so I can see the vertebral body real nicely through the cardiac silhouette. The spinous processes are a little off center. I'm going to try to highlight one here. There's one there, there. So it's not like equal distant to its eye. So the spinous processes are pointing that way, so the structures in front of it will kind of deviate this way, and that's why we see the trachea over here. I'll take this off in a second, and here's a spinal column. So this is a little bit of a rotated film, and I'll take this off again. A little bit of rotated film. That's why we see the trachea off over here and not right down the middle of the spine. And we see a little bit more of the right heart border on the other side of the spine. So this is a little bit of a rotated film. It's not going to mean much to our overall diagnosis of this patient, but we just want to know that maybe this deviated trachea is probably normal because the film is slightly rotated. I don't think there's any pathologic processes that forcing the trachea over there. So let's look. So that's airway. B for lung fields. So we're a little bit hyperinflated. We're going 1, 2, 3, 4, 5, 6. Oh, let me count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So a little hyperinflated lung fields. I see costopharyngeal angles, and I see lung markings at the periphery, but I see this hyperdense kind of area here, but not so in these corners. So I'm going to highlight what I see here. I see that there and there. And the heart borders here. Maybe a little bit larger, high normal, like on the heart side. So the heart side shows a little bit, normal high, I would say. Diaphragms, kind of a little hazy there. Got good costopharyngeal angles. Still no fluid down here in the costopharyngeal angles. But I have this pattern of this infiltrate here. And E, everything else, the bones look all intact bilaterally. I do see a white line here that ends about there, and that's probably an endotracheal tube. If we look at our right and left main bronchus, our carina is about here, and the tip of the tube is about there. And you want the tip of the tube to be at maybe at the bottom of the clavicle heads. See the clavicle is a little bit rotated. We know that because our spinous process is a little bit rotated. But this ET tube needs to be down here at the lower part of the clavicle heads and above the carina, about 3 centimeters above the carina. So I would say the tip of the tube needs to be here. So from here to here. So in this case, I would tell the respiratory therapist needs to advance the ET tube. Now on the viewing software that you have at the hospital, you'll be able to measure this on the screen. So sometimes you'll measure here to where you want it, and you say advance the ET tube down 2 centimeters or 3 centimeters. This line here comes all the way down is a gastric tube. I don't know whether it's inserted in the mouth or the nose, but it comes down here into the stomach. And then this little tube, this little device here is called an esophageal temperature probe. So the nurses can put that in to measure the patient's core temperature. And that will be displayed on the monitor. All right, so that's E, everything else. So with this pattern, it's called a bat wing appearance. It's almost like wings, and um, and this is what's called an acute um, pulmonary edema. Okay. All right. Technique wise, um, we have our spine through our cardiac silhouette. We have our spinous processes that appear to be somewhat equidistant to the vertebral body, and maybe a little bit rotated closer to this side than that side. Um, and the clavicle heads are about 3 to 4 ribs down, so angle looks good. So our trachea is coming down here, down the spine, and then it kind of separates here at the carina, right and left. Breathing field of lungs for breathing. I look at that lung field. I see lung markings, these little lung markings all out in the periphery on both sides. Then I look bilaterally. I see like this little hyperdense. I don't see it over here. I see it there. See cardiac silhouette. It's a nice cardiac silhouette. Aortic knob here. The ventricles. The atriums over here. Most of the heart is over here on the left side. Diaphragms. Good cosopharyngeal angles, both sides. I don't see any fluid in the cosopharyngeal angles. And probably a little hyperinflated. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. A little hyperinflated lung fields. Ribs. I don't see any rib fractures. I don't see any subacute air. This indicated left side. I don't see any hardware, but I see a little subtle, very subtle. That's why you gotta look both sides. Now you see these markings here, that's your hilum. Again, that's just blood vessels that are coming off to feed the lung parenchyma. So that's kind of a normal appearance on both sides, but this is different than over here. So interpretation is that there's a right upper lung mass there. In this case, we're going to evaluate our technique. We see hard to see the vertebral body through the heart silhouette. We start to see vertebral bodies here, the spinous processes here, maybe a little bit closer over to this side than that side, which might explain the trachea over here, but it might be equal distance. But so that might mean that the trachea is kind of deviated a little bit over to the right. So maybe a little bit underpenetrated, because you can see it's kind of really washed out on the periphery here. So maybe a little under penetrated. So we have to take that to an account, not to under or over read something. Trachea is a little bit mildly to the right. Lung markings are all out to the periphery here. No pneumothorax or anything like that. I don't see any consolidation or any pleural effusions in the bases or anything like that. Cardiac silhouette is starting to look a little wide. And the mediastinum, this part is called the mediastinum, all the great vessels of the heart, aorta, and vena cavas, pulmonary arteries and whatnot are in this region, and some lymph nodes and things like that. So this is a wide mediastinum. D for diaphragm. Kind of see on both sides. You can see the cosopharyngeal angles here. No air underneath that diaphragm. And E, everything else, bones look pretty much intact. Everything's all lining up. I don't see any hardware other than the EKG leads. but it's got a very wide mediastinum here. So the interpretation is here that this is consistent with a aortic aneurysm, and this is a medical emergency. So this is a cardiothoracic surgeon stat consult, or if you have interventional radiology at your hospital that can do endoscopy and like endovascular rather procedures where they can go up here and maybe stent that aneurysm. So you need to get these consults stat, and of course, as if patient is hemodynamically unstable, you need to manage that as well. So this is an emergency situation. Next case, technique-wise, you can see the spine very well through the cardiac silhouette. Spinous processes maybe a little bit to the left here. Clavicles are a little bit uneven, so it might be slightly rotated. So the technique-wise, not bad. So we can kind of continue on without like extra caution. So our trachea is kind of midline here. I can see the left main stem here, carina, a little bit of the right main stem, kind of hard to see, but the trachea is definitely here. This is B. I'm going to see the lung. I got these little wispy lung markings all the way out to the periphery here. Wispy lung markings with all the way out. I see good costopharyngeal angles. I don't see any consolidation or infiltrates or opacities in the lung fields. So that's B. C for cardiac silhouette. I see this really narrow, very, very narrow cardiac silhouette. I don't even see the right border here. I see the aortic knob here and the ventricles of the heart, but very, very narrow. Diaphragms look a little flatter, and they're almost like level, but these are much flatter diaphragms that we've been seeing in the other images. So very flat. So everything else, bones, all look, uninterrupted, no fractures or anything like that. I don't see any hardware or lines or tubes or wires. Everything looks fairly good. Now this is also an indicator for the left side, and there's also this little circle thing is a level. So these little beads in there, if the patient's sitting upright, will level at the bottom. If the patient was laying down on their back in a supine position, it'll be like a little triangle shape in the middle here. If they were laying on their side, it'll be layered out on the side, so that you can tell this is like a little level. So that's a little something different there. So here we have hyperinflated lungs, flattened diaphragms, and small cardiac silhouette. So this is all indicative of an emphysema type lung consistent with COPD or emphysema here. So hyperinflation, narrow heart silhouette, and flattened diaphragms. I think this might be the last rib here, so let's try to count. There's one rib there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Super hyperinflated. Next case, technique. You can see the spine through the heart. Little twist to the spine here. Spinous processes somewhat in the middle of the vertebral body, but the top of our field is cut off, so we can't see our apex. We can't see the top part of our lung fields here. So technique's not great. This is something, if I was concerned about a pneumothorax or something like that, I would want them to reshoot that image to include the top part of the lungs there. So we'll go along with our A, B, C, D, E. Trachea is kind of midline. I can't really see right and left main stems real well. So we'll go to B, lung markings. I got these wispy Lung markings all out to the periphery, so no pneumothorax anywhere. I don't see bilaterally any opacities or consolidations that are different. You see the hilar structures. That's kind of a normal finding. This little, again, structure here is the scapula. You see the scapula here. So don't see anything wrong with the lung field per se. Cardiac silhouette. Got a little bit of on the right heart border, left heart border, aortic knob. The size appears normal. I would say that was in the normal side, or maybe small side of normal. Diaphragms a little bit flat on this side, a little flat on that side, almost the same height. So maybe this patient does have a history of COPD or whatever, but I can't really count going this way now because I don't have the top part of my ribs, but I might be able to come up here a little bit, but definitely hyperinflated. So E, everything else. So I'm going to look at the bones. I don't see any hardware. I'm going to look bilaterally, just follow the ribs, and then I see a continuation here, a little line right there. So this is a rib fracture of the 7th rib. Now, when you see a rib fracture, you definitely want to look again at this border. Make sure you don't see a line that goes up here that indicates there's an air in here and a partial collapsed lung. Also, if you have an air leak here, you might see air leaking into the subcutaneous tissue, and you see little black bubbles in this soft tissue, and it'll be different from this side. But these two different sides look fine, so it doesn't look like there's any subcu air. Doesn't look like there's any pneumothorax, just a fractured 7th rib. And because we can't see the apexes up here, sometimes if there is a little bit of air leak that can track up the pleura and kind of collect up here, well, it's this side, it might just be mostly on this side. Sometimes you can see a little pneumothorax at the top here and may be related to this. So since I saw this, I'm going to ask the radiology technologist to retake the x-ray to include the apexes. Next case, this is an unusual case. This is something that I mentioned prior about looking at previous studies, because this was very helpful in identifying the problem with this patient. So technique-wise, this was the prior study. You can see the vertebral bodies through the spinal processes in the vertebral bodies. Here, it's a little bit more difficult to see. I kind of lose the spine here. I can start seeing the spine up here, but we're outside the heart silhouette now. So very hard. And plus, it just seems more whited out here. So this might be like an underexposed film versus this film. And these are the same patient, actually. So B, on this film here, wispy lung markings all the way out to the periphery. Really no consolidation. You might see a little bit more hazy versus up here. A little bit more hazy than versus up here, but that's probably for the excess tissue from her breast. This is not like an infiltrate or whatever, just extra tissue. So it's a just normal finding. So the lung fields look fine on this side. Over here, again, I got some lung markings all throughout. Again, a little bit more hazier down here. Could the breast tissue go through more material per se, I guess. C, heart silhouette over here looks normal. Aortic knob, right or left side of the heart, ventricle, left side of the heart, and over here, much bigger. I can't see the really costophreneal angle over here. It's just kind of washed out a little bit. Bones, they all look intact, nothing broken, no sub-Q air. So we had an acute change here from one to the other, um, and it got this enlarged heart. So this is something I'd be really worried about pericardial effusion, something that happens really fast. This type of thing, if this was heart failure or cardiomegaly, this is something that takes a very long time. But this was an acute change over just a couple of days, and so this is the benefit of looking at prior studies. And she wound up with a pericardial effusion, and they had to put a catheter in and do a pericardial centesis. And this is also could be a medical emergency because this fluid builds up and can cause cardiac tamponade, where it's squeezing the heart and it can't generate enough cardiac output or blood pressure. So this is an emergency. This is something that you need to call a cardiothoracic surgeon, or if you work in an ER, that ER physician or if a PA is trained can place a catheter under at the xiphoid into the pericardial space to drain the fluid. They may ultimately need a pericardial window by the cardiothoracic surgeon, but that would all depend on the etiology of the cause of this. Next case, technique-wise, can see the spine through the cardiac silhouette. The spinous processes are pretty equidistant. Clavicle heads are about 3 to 4, so this is a good technique. Just looks a little different, but from a diagnostic standpoint, I can definitely use this X-ray. Trachea is midline. Here's the carina here. You got the left main stem and a right main stem, so carina is about there. B, I got lung marking. There's little wispy lung markings all the way out to the periphery, both sides. I can, the costopharyngeal angles are a little bit cut off here, but pretty much clear lung fields. C, cardiac silhouette, mostly on that left side. It's a normal cardiac silhouette, aortic knob. D, diaphragm, nice dome diaphragm. Right is higher than the left. So kind of normal, there's no air underneath the diaphragm. The left side is a little bit cut off, but E is everything else. The ribs seem to be doing fine. No sub-Q air at both sides, but I do see a catheter here going to the superior vena cava, maybe into the right atrium. So this is called a central venous catheter. So it's inserted into the right IJ or internal jugular via ultrasound, and it will come down the superior vena cava into the right atrium. Sometimes you'll see them placed here, and it'll kind of bend down to the subclavian vein underneath the clavicle, and come down here. But most of the time you'll see them here. And you'll see 3 lines coming off the single catheter. So this is a triple lumen central venous catheter. So this patient needed subvascular access for some reason, so they placed that there. And you do an X-ray after a procedure like this, because you're sticking needles here, and sometimes you might cause a pneumothorax. Pneumothorax are more common with a subclavian approach than an IJ approach, but also you want to make sure that this catheter is in the right place, and it is. If sometimes it's too high, or sometimes it can be too low, it can go deep into the heart, and you want to kind of retract a little bit. But this is a proper placement of a right IJ central venous catheter with no complications. There's no pneumothorax or anything like that. So central venous catheter, no pneumothorax seen. So I place these lines in the ICU, and I'll do an X-ray after I place this. I can put one on the left side, and I'll kind of cross over and down, you want to make sure you use a little bit longer catheter to make this transition over. Sometimes this can find different anomaly veins and go a different way. Sometimes this will come down and circle back into their brachial. So you want to make sure it's in the right place. And also, when I look at this and it's good here, no pneumothorax, I put an order in, okay to use right IJ CVC. This is just more examples of central venous catheters. This is called a PICC line, which is called a peripherally inserted cardiac catheter. So it comes all the way from the periphery over. This patient is also intubated. We're not going to go through all. This is just some examples of different catheters. Looks like there's a larger catheter coming down this way. I'm not really quite sure what that is, but there's something there. And then you have a gastric catheter that comes all the way here. This is a portacath. This is placed under the skin into the right atrial area. It's a central catheter. This port is actually embedded under the skin, and when a patient goes, say, for chemotherapy, the chemotherapy nurse will place a needle into this port, infuse the chemotherapy, and then take the needle out. In an ICU setting, when we have a patient that is not doing well and needs emergency access, we can access this to use it to infuse medications. If it's a new catheter, they like you to kind of stay away from it, and then I'll have to put a new one in, and you'll have another catheter coming down next to this one. But if it's kind of a mature catheter, we can use it. There's just a technique to do it. There's a sterile technique to cannulate that. But it also looks like this patient might have a pleural effusion here. Okay. All right. We're getting down to the home stretch here, folks. All right. So this evaluate technique can see the spine through the cardiac silhouette. Spinous processes are a little bit rotated, over to the right side. So structures might, the anterior structure, like trachea, might be a little bit more to the left, but not bad. So it looks like it's well penetrated, and angulation 1, 2, 3, 4 looks like it's a good angle. So we can go ahead with confidence and read this X-ray. So trachea is midline. You can really see the carina really well here. Here's the left main stem and the right main stem. So there's a midline. So B, lung markings. I see all this wispy lung markings all the way out to the periphery. I don't see any consolidation or opacities bilaterally. I can see the costophryngoscope. This one's a little bit cut off, but this one is nice and crisp. C, cardiac silhouette. Looks like it's a normal sized silhouette, mostly on that left side, so it's normal placement. D is diaphragm, a little bit more flat on this side, a little flat. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10 and a half. So a little bit hyperinflated. Now E is everything else. Bones looks intact bilaterally. I don't see any sub-Q air on either side. I do see a breathing tube here, the tip there. And you can measure this from the carina to the tip here, and you want to be about 3 centimeters, like 3 to 5 sometimes. So you don't want to get too close, because you might go into the right main stem, and you don't want to be too far, because then it might come out of your airway. So about 3 centimeters here. So that looks good. It's the tip of the tube is near the bottom of the clavicle heads, so that's a satisfactory positioning. And I don't see. Okay, we see a gastric tube going down here, can't see where it ends up, but it's probably some sort of gastric tube there. And we got our EKG clips on, and this is just a button um, from their gown. So this is endotracheal tube, maybe slightly high. I have to measure this, maybe come down a little bit. It's just slightly high. I would advance. This is another airway. It's called a trachea or tracheostomy or trach. It's in place of the temporary breathing tube that we've been seeing lately. This is a little bit of a side profile on it. So it just goes into a surgical incision. A stoma is created in the trachea, and then this airway device is placed in and then secured around the neck with a necktie. And this is what it looks like outside. Here's the flange. That's this flange here. Right now it has a purple obturator in. That's what it's called. This is what you place inside the trach before you insert it into the stoma. And of course the cuff will be deflated. This is showing the cuff inflated. So once it's in, you would inflate that cuff. This one's cuffless. It comes cuffless or cuffed. And this one's cuffless because this patient is probably further along in getting decannulated, meaning this coming off is not dependent on a ventilator. This one, we can inflate the cuff and seal it off and place them on positive pressure ventilation or ventilator. So once you insert this into the stoma, into the trachea, you then place a syringe with air on this pilot balloon and push some air in, and that inflates the cuff. This other catheter is more for secretion control. This is another tube that comes down the side, and any oral secretion that comes from above will collect here, and this hook does suction, and you can suction that out so it doesn't go into the trach. So once it's inserted, you pull this purple obturator out, and you put this in inner cannula in, and it kind of snaps in place, and that's what that is. So this is what it looks like. Again, the tips of that should be at the bottom of the clavicle heads, because this does come in different lengths. So you can see that. So this is a picture of what it looks like to be trached. So here's the flanges here. You can kind of see the flange here. This patient also has a port, some sort of metaport, and looks like some sort of vascular repair or stenting of some sort of here. All right. Here's an example of a breathing tube that's inserted too far. You kind of see it kind of going into the right mainstem, making a little right turn into the right mainstem. So this is too deep. Remember, you want to be kind of at the bottom of the clavicle head, so you need to retract it back up to there. And you kind of see the left hemidiaphragm higher than the right because you're administering positive pressure ventilation just to the right lung and denying air to the left. So this just starts collapsing, so your diaphragm will be higher. So, so you want to retract this out so now air is evenly distributed to both sides, and this diaphragm will come down. This lung will reinflate and then it will come down. This case, okay, so technique wise, got a thoracic spine here, but I don't see a cardiac silhouette. Spinous processes here are kind of in the middle. Clavicle heads are about level, so the angle is good, and the penetration is good. So airway deviated way to the left. Left main stem, right main stem, carina. Lung markings over here. Now if you notice, it's kind of streaky. It's not that wispy, kind of branch looking lung markings that we saw before. So there's a lot of streaking here. On the left side I don't really know what to make of this. It looks denser, thicker. This is all just real consolidated. I don't really see anything. That would be normal. Cardiac silhouette, I don't really see. I can't make out any cardiac silhouette. Diaphragm, this is kind of way flat, hyperinflated, way flat. I can't really make it out. I can kind of see an air bubble here in the stomach, but I can't really make out the left diaphragm, not visualized. Now I'm going to look at bones. The bones look all kind of intact everywhere. I don't see any broken bones, but now I'm looking bilateral soft tissue, and I see some dark streaks here, but I don't see it over here. So this is what's called subcutaneous emphysema. So this is a large pneumothorax. It's pushing all the air over, they're pushing the lungs over and pushing all the structures over to the left. And air is leaking out here into the soft tissue. And that's why you see it all tracking along here and not here. And the air is actually tracking in the chest wall over the thoracic, the rib cage here. So that's all, this is all subcutaneous air in the tissue over the chest. This is not lung markings. Here, you start seeing lung markings, but here is all subcutaneous air in the tissue over the ribs. You also see a chest tube here in the left side. So they're attempting to reinflate this lung by putting this chest tube in to evacuate this air so all this lung structure can come back over. So this is a right tension pneumothorax with a right chest tube and subcutaneous air. So this is with this chest tube in, you should see the structure improve rather quickly. This is still a medical emergency if this doesn't correct itself, because this patient's probably in tension right now, meaning the heart is very squeezed, not generating a good cardiac output, not generating a good blood pressure. The patient's probably going unconscious. There's no artificial airway in here yet. And there's no other vascular access going on here. So this is still an emergency. And this type of situation, if this chest tube's not working, you have to put another one in. Sometimes, even though this chest tube looks like it's inside the chest, if it's not placed right, it can actually ride under the skin above the ribs and could not be in the chest cavity. So that's why a second one might need to go in. And also you want to check this whole line, make sure it's hooked up to a Pleurovac and suction and all that stuff. And that'll be another talk. But you need to troubleshoot your equipment if this is not being corrected. This is still a medical emergency. Technique-wise, you can see the thoracic spine through the cardiac silhouette. Can't really see the top, you see the rotation. The trachea is a little bit over here, and the heart margin's a little bit on the right side, so I would imagine we're probably rotated. But this is just an example of a gastric tube placement. So we see the bat wing like we did on the previous one, but this gastric tube comes down, it goes past the diaphragm into the stomach and kind of curls around a bit. My first impression would be that this is kind of inserted too far and could be, maybe pulled out a little bit. There's been cases where gastric tubes have been inserted too far and actually the tip has perforated the stomach wall. So typically in adults, the placement of this is about 60 centimeters at the nose. There's markings on this tube. So I usually just aim about 55 to 65. If I start hitting resistance at 55, I kind of cool it, and then I'll put a stethoscope over the stomach here, and I'll push some air down the gastric tube with a syringe, and I can hear air escaping out of the tip here, then I kind of know I'm in the right place. If I don't hear it here, but maybe I hear it here, that means the tube may have gone down the right main stem. So you want to make sure you hear it over here, and of course get an X-ray, or what's called a KUB, which is a kidney, ureter, bladder chest X-ray. So it's like a abdominal X-ray down here, but sometimes you can see it on the chest X-ray. So this is a gastric tube that overlays the stomach. So that's an example of that. So technique-wise, I see the spine through the cardiac silhouette. I don't really see the top too well. I do see a little bit of the spinous processes here. Trachea is a little bit deviated to the right here, but the spinal processes seem to be equal distance, so not too rotated. Clavicles, can't really see the top rib, so I can't really count down, so I don't really know. So the top part, which probably really needed, but not bad. And for what I need it for, it's not a bad technique. So so airway a little bit deviated to the right. Breathing fields, again, kind of hazy throughout. A C cardiac silhouette, kind of normal size. Diaphragms, this one seems kind of sloped down. This one's kind of domed. D, everything else. Ribs seem to be okay. Got a med port here like we've seen before. But we have this gastric tube that's coming down here, right down the trachea, right down the right main stem, all the way to the distal airway to the right base of the lung. So this is a malplaced gastric tube. So this is where you want to mark, if you're hitting like 45 and start hitting resistance, then I wouldn't push it anymore and just kind of figure out what you're doing. You can put some air down the syringe into here with your stethoscope over here over the stomach. We don't hear anything. You're in the wrong spot. So this needs to come out. If this patient was awake or kind of semi-awake and have a cough reflex, if you start inserting this down their nair to like a nasal gastric tube, and it actually goes between their cords into their trachea, you'll probably elicit a cough reflex, and the patient will start coughing, and as you insert it more and more, the patient's coughing more and more. They really shouldn't cough with a gastric tube insertion. Sometimes it may gag a little bit because it's going back to the throat and stuff, but once you get into the esophagus, that all kind of stops, and they shouldn't really be coughing. So if they're coughing, you're in the lungs. And also, when you start hitting resistance, you don't want to push. So if you start hitting the resistance here, you may be in the lungs, and I want to keep forcing because you could perforate the lung as well. And also listening over the stomach by pushing air will give you an indication that you're not in the right place, and this just needs to come out. There has been cases where this has been inserted and they haven't checked or did an x-ray, and they started tube feeds and whatnot, and they put tube feeds into the lung. So just be careful. So that's the end. Thank you for listening. When you do chest X-rays, please create a system for your evaluation. Like I said, I like to use the ABCDE method, and when you utilize that with every time you look at an X-ray, you will reduce the likelihood that you're going to miss something. When you order an X-ray for a specific reason, just don't look at that area that you took it for. Go through your system, do the ABCDE, look at the entire chest X-ray, because you may pick up something that you weren't looking for. And you'll be less likely to miss something. So it was a pleasure talking to you all. If you have any questions, please email me at the email address provided, or you can contact your course director. Additional resources are suggested by the textbooks that your course director has suggested. I'd like to go to radiopedia.org. They have not just chest X-rays, but CAT scans and MRIs and different things you can preview, and also pvemedical.com. They also have a chest X-ray interpretation little slideshow, which is excellent, just to kind of refresh yourself. And thank you very much for your time, and good luck.